We are live.
Good evening. Welcome all. As the cold wave grips the country, I would extend a warm welcome and a happy new year to everybody watching this live. Welcome to the AIOS Guru Sangam 2024-2025 edition, where we educate, elevate, and excel at the heart of what we do. Today is the session one on optics and refraction. To help us put together and under the aegis of our President and Chairman, Dr. Basak, and the Program Directors, Dr. Honavar and Dr. Mathur, I shall be moderating this session for you. Today we have an expert panel comprising Dr. Rajendra Singh Chauhan from RIO, PGIMS, Rohtak, Dr. Shreya Tharte from Sri Aurobindo Institute of Medical Sciences, Indore, and Dr. Uma Kulkarni from Yennepoya Medical College, Mangalore. We have three speakers for this evening. The first to go would be Dr. Chandrasekhar. Though he needs no introduction, here is a brief of the same. He has his MBBS, Diploma in Ophthalmology and Masters from the Madras Medical College and has been actively involved in teaching for the last 28 years. He has been conducting quiz at various forums for the last 2 decades. He's the lead for the NABH compliance for Arvind Eye Care System, which comprises 14 hospitals right across the length and the breadth of our country. He is the co-chairman of the AIOS Adverse Events Committee, the chairman of the TNOA Quality and Infection Control Committee, and a certified NABH SSR. He's an expert member for creating the first edition of the NABH Eco Standards, the first ophthalmologist to become the QCI WASH SSR during the COVID times, a certified professional for quality implementation in hospitals, and certified professional for hospital infection control. He's written chapters regarding the NABH standards in AIOS Times, TNOA Journal, and AIOS ARC booklet on accreditation of the eye centers. He's worked with 21 hospitals for NABH implementation and is the co-host for the VRVDC online forum for ophthalmology PG training and the founder of the TN Ophthal PG forum. Today, he shall speak to us on astigmatism, the stigma beyond the enigma of strums. Over to you, Dr. Chandrasekhar.
Thank you so much. Am I audible, sir?
Perfectly
Yes, you are
well.
audible.
There's a small change. My topic is retinoscopy simplified, sir.
Sure, sir.
It's
Sure,
okay.
sir.
Yeah. So let me
Very
share
good
my
evening,
screen.
Dr. Basak. We are able to see you, sir.
Yeah, 1 minute.
Good evening.
Good evening. Good evening, Dr. Samar Basak. Good evening.
So
Very
you're
good
muted,
evening,
sir.
sir. Is my blank screen visible, sir?
Yes, sir. Perfectly well.
So, vanakkam to all of you from South, from Tamil Nadu, Coimbatore. It's a warm evening. So, at the outset, I'd like to thank the Honorable President, Honorable General Secretary, Treasurer, and all the panelists here, along with the experts, for this opportunity to be the opening batsman of the Guru Sangam, which is a wonderful PG teaching program. I'll straight away go into our talk. So, what does everybody, most of you are PGs, think is a foundation to success for any eye hospital? I'm sure a lot of thoughts come: best outcomes in surgery, happy patient, and so on and so forth. But we must remember a good refraction and a wonderful visual acuity we give the patient is the foremost important thing. Many a times it is the optometrist or the refractionist who take care of this, and sometimes some of us end up signing whatever they give. So this foundation from a PG time, you must know whether whatever is being given to the patient is absolutely right or wrong. So this topic is going to be on a art which is called retinoscopy. Even though we have one of the best equipment, many of the equipments to find out the refractive status, retinoscopy is a wonderful method to find out a status of a patient. Eventually, we want to give them a wonderful 6/6 vision. This best corrected vision, if we can give either as a refractive patient, postoperatively, or anything, is the one which the patient also wants. Just a short introduction as we moved, from the dinosaurs era where we had a 360-degree vision with the eyes placed laterally, we have come to anteriorly placed eyes with a wonderful three-dimensional vision. Do we have the best vision These are some of the facts which you will be shocked to know that 16 cones are there for the mantis, 270 rods, 12 eyes for the caterpillar, and reflective layers are there for the whale so that they can see brightly in a dark area. You won't believe housefly has had 4,000 lenses in each eye, and more importantly, the dragonfly has 30,000 lenses. So, in spite of all that, do we have the best vision? We have a sharp vision, good binocularity, depth perception, and color vision. Is it the best? No, definitely not. The eagle has got a better vision than a human being. That is why we say eagle vision. And the field of vision is wonderful for these organisms and this kind of animals like cheetah or leopard, where they have a very good blind spot, and from a long distance, they have a wonderful binocularity. As a refractive apparatus, there are two aspects inside the corneal system and the lenticular system. In the corneal system, we have about 43 diopters of power, and the lenticular system contributes around 18 diopters of power. More importantly, the refractive indices at various levels, starting from the cornea till the vitreous, will also play a role. Especially, you all know a nucleus cirrhosis can produce an index myopia. So when a child is born, they do not have a 6'6". I'm sure there are a lot of newer PGs here who have just joined about a week or two back. So it is only about 460 to 660, and they are hyperopes. Then only they'll become an emmetrope, around +2 to +3 diopters. There are some things which are not actually refractive errors, but they are induced by conditions like a lid swelling producing an astigmatism, or iridocyclitis producing ciliary spasm, relaxation, and producing myopia. They are called induced refractive errors. How do we find out a refractive status of a person, whoever it may be or whatever the age may be? There are two ways. One is by putting the lenses and finding out subjectively whether they are all right or not. But the better method and the best method would be the objective method. This retinoscopy, Sir William Bowman said there is a regular astigmatism we can see in ophthalmoscope, and it was this person called Ferdinand Quignet in 1874, who's called the father of retinoscope, created this retinoscopy. Even before 1285, there used to be glasses given for farsightedness and glasses for near vision in 1430. It has been going on. This is the older method, like the Chiron lamp behind the patient's head, and then this is the reflecting retinoscope. Now, assessing refractive status, in the objective type, we have retinoscopy, autorefractometer, photorefractor, and so on and so forth. Now, this talk is going to be on retinoscopy, which is a wonderful art to find out the status of the refraction of the eye. When light is reflected from a mirror or a self-illuminating retinoscope, it is projected into the eye. The direction in which the light will travel across the pupil, depending on the refractive status of the eye, and forms an image. This is the basic principle of retinoscopy. In retinoscopy, there are three stages. First is illumination of the subject's retina. Then there is a reflex image illuminated by the illuminated area, and where the image is projected. The image can be projected behind the patient, at the patient, between the patient and the observer, at the observer, or behind the observer. Depending on where it is projected, we'll see all these reflexes. So these are the three stages. So the ones on the left side are the reflecting retinoscopes, and the one which we use now are the self-illuminating retinoscopes, which are electrically or battery operated. Now, if you look at retinoscope, there are two models. One is called the Copeland model. Hardly anybody uses in our country now. The Welsh-Allen model is the one which we use. It is half silvered. So if you see the retinoscope, there is a sleeve which can be pushed. You can either use your thumb to hold it. The sleeve can be at the bottom or at the top. You must remember the Copeland is the other way around. If the sleeve is at the bottom, it is a plane mirror position. If it goes up, it becomes a concave mirror position. So we are going to do majority of our retinoscopies only at the sleeve down, which is the plane mirror position. Now, what does the sleeve up position cause? It causes a concave mirror, a type of retinoscopy. What is the use? There is no major use except that there is very high minus powers or myopes. We can use this concave. But remember, from plano, if you go towards concave, what is a with reflex will become against reflex. The reflexes will change, which you will be understanding within the next 2 or 3 slides. So what are the types of retinoscopy, dry or wet? By wet, I mean you put any cycloplegic like a homide, omatropine, or atropine, or cyclosin, tropicamide. But please remember the plus we use, tropicamide plus, where there is phenylephrine, it is only a mydriatic and not a cycloplegic. If you do without any kind of cycloplegia, it is called dry retinoscopy. If a person is looking at a far object like your Snellens or something, and then you are going to do a retinoscopy, that means he's relaxing his pupil, the ciliary body. It is called static retinoscopy. More accurate would be dynamic retinoscopy, where the person looks into the retinoscopy light, but that will be more difficult because the pupil is going to constrict further. So this is dry. When we do a retinoscopy after application of a cycloplegia, it is called wet retinoscopy. Now, at what distance we work? Normally, we work at 2/3 of a meter, which is usually the normal arm's length, so that you can sit in front of the patient, remove and take the lenses and change the powers. And 1/2 meter is very close. But for practical purpose, in this presentation, I'll take 1 meter, which will be easier to calculate. So when I work at 1 meter, I'm not going into the eye of the patient, but I'm going to be away at 1 meter. So I must give a correction for the distance from which I'm working. So for 1 meter, I'll do a -1 diopter. 2/3 of a meter, I will do, you will put 3/2, it will be 1.5 correction. And 1/2 meter, it will be -2. But remember, farther you're away from the patient, more accurate it will be. Closer it will become less accurate. For example, if you're going to do a retinoscopy at 20 centimeters, that means for very, very high powers, it is called radical retinoscopy. The accuracy may not be as good as 2 meters or a 1 meter, but that is because the reflex will be dull, movement will be dull. So you can do at a very close distance and make accordingly the kind of distance correction. Now, here you can see there is a reflex. This is what you're going to see. You can see the trial frame, there is a pupil. You can see the iris above and below. You can see the movement of the reflex. This is exactly the viewer's view of how it will look when you do a retinoscopy. Now, these are model eyes which are available. You can set the power, you can set the axis. And I suggest that each of your institutions, you ask if you don't have one, to buy this, which is hardly about 3,000 to 4,000 rupees. You can practice your retinoscopy on this and then go and try on the patients. Instead of first time sitting on a patient and sitting for half an hour, 1 hour, it is not good. These are absolutely wonderful model eyes for retinoscopy, which will be very useful. Now, if you are going to characteristics feature of the retinoscopy reflex, when you saw the reflex moving, so there are a number of things that can occur. If it is slow, that means your neutralization point very far away from the focal point. It becomes faster and faster. That means you're nearing the focal point. Similarly, large refractive errors will be very much away, and faster will be smaller errors. Now, if it becomes brighter and brighter, that means you're nearing the focal point. If it is dull, you're away from the focal point. Actually, it will be very wide and diffuse as if you are away. When you reach the neutralization point, it will become narrower and crisper. These are the reflexes which will give a clue as to what you are doing about the retinoscopy reflexes. Here you can see there are 3 types of things you are seeing. On top is the reflex with the movement. Then there is hardly any movement. And the third one is against the movement. So I'm not going to explain this. Only thing, remember, against the movements mean the image should fall between the observer and the patient. Only between the observer and patient, it will become against movement. If it falls at the observer's eye, it will be no movement. Everything else will be with the movement. This is the basic principle of how we get with against the movement. Now, here you can see now a retinoscopy being done. Here you can see it's with the movement. Can you see the beam is moving one side and the reflex is also moving to one side. This is called with the movement reflex. Now again, if you see, okay. Now you can see this reflex is against. Beam is moving one side and the reflex is going again. Unless you sit and do practically, you will not be able to observe. This is exactly what you will be observing. Within a few days, once you start doing regularly, you will get control over your arm, your wrist and your finger, and how you can do it very fast. But only thing you need is a practice. Now, this is the place where we call neutralization. Retinoscopy ends. That means pupil will become completely filled. There will not be any movement at all, with or against. Then this verification can be done with overcorrection. Supposing at +2, it is no movement. If +1.5 would have been with movement. So you remember, when it is with movement, you put plus lenses. Don't take it as hypermetrop, myope and all. If you have a with the movement, you put plus lenses to neutralize. If you have against movement, you put minus lenses to neutralize. Okay. So +1.5, I'm getting with the movement. +2, no movement. If I put +2.25, it will become against movement. It will reverse. Similarly, -1.5 against movement, -2 no movement. If I put -2.25, it will become with the movement. So these are the features of a neutralization. Now there is another thing. Here you see the beam going 90 degree or 180 degree. However you go, it will be parallelly going. We have a condition called as astigmatism, which will have a different kind of reflex during retinoscopy. So if you see here, if you are moving the beam like this, the streak will be in some other area. Normally you will have three lines, one at the iris, second at the pupil, and then below. Now this is called the break. This is the first sign of an astigmatism. Similarly, width will vary, whether it is more wider or narrower. As you come closer to the same axis, it will become narrower. This is the width, second point. The third one, when you come closer to the actual axis, it will become brighter. So you have the break, the width, and the intensity. The last one is called the skewing. Here I'll show you. This is called as skewing. You can see in the previous one we saw they are on the same axis. Now now when I align both of them, they become same. This is called skewing. Okay, this is called skewing. If you overcorrect, again skewing occurs. So you have 4 points. One is the break, second is the width, third is the intensity, and the last one is called the skewing. So how do we confirm whether our axis is correct? I'm sure all of you would have heard about Jackson's cross cylinder to find out whether the axis is correct for the glasses. Similarly, in retinoscopy, we can take 45 degrees. So if I'm neutralizing at 35, then I go 45 degrees on either side. That is called straddling. So all the breadth, your width, your intensity, your break, and skewing will become equal on both sides. If it is not equal on both sides, you have to adjust. Unless you sit and do with your retinoscope, you will not be able to do a 45 degree this side. You see the skewing and the width. 45 degrees the other side. If both are equal, that means your axis is correct. So this is not to find out the astigmatism. This is to confirm axis is correct. So to find out it is an oblique axis, you have width, you have the break, you have the width, you have the intensity and the skewing. So these are the points you should know. When you have a cataract or a media opacity, you can have a faint shadow, dull shadow. Sometimes you have a central cataract or peripheral, you can have shadow in the center, difficult to neutralize all these conditions. Then you have the most important thing called scissoring. Two bands of reflex. You can see it is like a scissors. So when I show you the actual scissoring reflex, you can see one is going with, one is going against. So both will cross like a scissor. This is called scissoring. This is very important to find out without even dilating. Now, of course, we have topographies which can do dilated topography also. Previously, we have to send it without dilatation to find out a keratoconus. One of the important conditions where you get the scissoring reflex is called keratoconus. You can see the beautiful scissoring of the reflex in retinoscopy. So we put drugs. I told you, you can put tropicamide, you can put cyclosin, homotripin, or atropine. Now, when you want to give a drug correction, you don't put dilating drops. We do not do a wet retinoscopy for all cases. If you are doing a wet retinoscopy, like how we do a correction for the distance, you must give, because what you're going to do is you're going to paralyze the ciliary body. You have to overcome that and give a correction. We do not give drug corrections for all powers. Remember, there are only 4 powers you can put in the lens. One is a plus sphere, next is a minus sphere, either a plus or a minus cylinder. You give drug correction only for plus spheres. You give drug correction only for plus spheres, with the exceptions of wherever there is no accommodation. When there is no accommodation like aphakia, pseudophakia, we forget about the accommodative IOLs. Aphakia, pseudophakia, and presbyopic age, all these three conditions, there is no accommodation, so there is no need for a drug correction. Mixed astigmatism, I'll come to it at the last. There again, a plus sphere will become a minus sphere, so we don't give. Never give drug correction for minus spheres or cylinders. This is the principle. Okay, so distance correction I've already told you. For atropine, you give a drug correction. Supposing it is plus 3, you give minus 1, it will become plus 2. For homatropine, we give 0.5, cyclopentolate 0.75, and tropicamide 0.5. At this point in time, I must make a statement. This is little controversial. Some of the examiners don't even say, this is correct, that is wrong. In general, this is followed in many institutions. Some may be telling you this is the correct way, that way, don't argue. But the principle of drug correction and the amount of drug correction is what I have put in here usually. Okay, this is important. Now, if you have a power like this, if you're going to have plus at 90 and minus, see the straight line and minus at 180, it is called with the rule astigmatism. Dash minus 180 plus 90, all this is called with. Opposite of this is called the against the rule astigmatism. So these are some important factors you must know when you do a retinoscopy. Apart from that, we have another factor. If it is 45 degree, supposing it is 45 degree, what is the other axis in regular astigmatism? Add 90, 135. Supposing it is 60, 150. It will be regular astigmatism, cutting at 90 degree. Only other regular is bi-oblique, opposite axis will be same. But we don't do that. So remember, if it is not at 90, 180, you call it oblique axis. If it is 90, 180, minus 180 plus 90 is with, opposite is against the rule. Now, this is something which is important. I'm going to teach the steps of retinoscopy as a PG so that you don't make a mistake. Once you become an expert, then you can do everything in the spectacle frame. You can do calculations in the mind and all this. Supposing they give a retinoscopy case in the exam, they will tell you this is the case. Usually, they will give you a dilated case only for retinoscopy. So here, the distance at which you are going to do is 1 meter. If you're doing a 2/3 also, it's okay, no issue. The age of the patient, you must know, 50 years, and tropicamide. Supposing pseudophakia or aphakia or all those things also will be told. Now, when you do retinoscopy, we'll talk only about a regular power. Now, you've got the 90 degree and the 180 degree. Your neutralization power, this is called the power cross, retinoscopy value or the power cross. At 90, it neutralizes at 3.5 and 2.5 at 180. So what did I tell you? The distance correction would be -1 because I'm sitting at 1 meter. So what will happen? Yeah, most of it will be correct, easy for you all. 1 minute. So here you can see 3 point, just subtract 1. Plus 3.5 will become plus 2.5. Plus 2.5 will become plus 1.5. At this point, just add -1. Supposing it is minus 3.5. If you put -1, it will become minus 4.5. Don't say minus 2.5. Okay. Just plus 3.5 minus 1 plus 2.5 plus 2.5 minus 1 plus 1.5. This is after distance correction. This is the first step. The second step is called subjective. Okay. After retinoscopy, distance correction. And the third one is called the subjective verification. So you have this plus 2.5 and 1.5. First is called the retinoscopy value. Second is the distance correction. And the third we are going to do is subjective, put the patient and make him sit. So this is the value after distance correction. There are two powers. Choose the lowest power, ideally. Which is the lowest power? Plus 1.5. So if I put plus 1.5 diopter spherical, it will be there 360 degrees. Spherical will act all 360 degrees. So you have at 90 and 180 plus 1.5. But what do you want at 90 degree? You would like to have a plus 2.5 at 90 degree. Isn't it? So already 1.5 is there. I need another one. So 2.5 minus 1.5. That is one more only you need. So you add that additional plus 1 for cylinder. If I give at 180, it lacked at 90 degree. Remember, if I give at 90 degree, it lacked at 180. But here I want it at 90 degree. Correct. So I give a plus 1 at 180. So what is the subjective power? Plus 1.5 diopter spherical, and plus 1 is given at 180 degree. So this is the power for the patient. Okay. This is the subjective value. This is okay. Patient is reading 6.6. Your retinoscopy is good. Your distance correction subjective is good. But what is the problem here is, when we give glasses, there is always a equivalent power. Many ways we can create equivalent powers. They are called transpositions. Usually, a minus cylinder will be better acceptable than a plus cylinder. Acceptability by the patient will be better with the minus cylinder. There are many spherical transpositions, cylindrical, spherocylindrical, and toric. What we are going to see here is a spherocylindrical transposition. So I would like to get a minus cylinder. So what you do, first step is algebraic sum of both. What is plus 1.5 plus 1? It is going to be plus 2.5. That will become spherical. Okay, algebraic sum of both 2.5 will become spherical. Here this will not change. Change the symbol and the axis. That's all. You can see here now. You have done a transposition. 1.5 plus 1 is plus 2.5 after spherical, and a minus 1 at 90. That's all. This is done. You follow? Algebraic sum becomes the spherical and stay in the symbol and the axis, opposite axis. So this is, now you are getting your minus cylinder, same equivalent power, and this is plus 2.5 plus 1.5 equivalent. One way of verifying whether your spherical is correct or wrong, you go back, the other axis will become spherical. We took 1.5 first, isn't it? Now, when you transpose, it will become the other axis. So, plus 2.5. That means you're correct. Okay. So, once we are done, the next step would be drug correction. So, we gave tropicamide. What is the age of the patient? We said 50 years. So, at 50 years, presbyopia, no drug correction. Isn't it? The sixth step would be near vision. At 50 years, I'd like to give age corrected. If I say age corrected, at 41, at 45 plus 1.5, at 42 it can be 1.25, 48 could be 1.75, and 50 will be 2. Can go up to a maximum of 3. So for a 50-year-old person, the plus 2 is the near vision correction. The seventh one would be the glass prescription. So what did we find out? Plus 2.5 is the spherical power, minus 1 at 96.6. So these columns, this is for one eye. This is the distant vision. Near vision, I told you add. So add, where do you add? You add only to the spherical. Cylindrical axis will come down. So plus 2.5 plus 2 becomes plus 4.5 minus 1 at 90 and 6. Now what is the diagnosis? Here there will be one confusion amongst all of you. Aha, one spherical and one plus and one minus. Many of you will tell it is a mixed astigmatism, which is not correct. Only look at the distant value. Don't look at the near value. Okay. So this is actually, I'll tell you why. Compound hypermetropic astigmatism. Okay. So minus at 90. Is it with the rule or against the rule? Minus at 180, straight line only with the rule. Here it is minus at 90. It will become against the rule and presbyopia. So the diagnosis for this patient is compound hypermetropic astigmatism against rule with presbyopia. This is simple. Plus same thing. I'm just going to revise fast. 3.5, 2.5 minus 1, 1 will become plus 2.5, 1.5. Subjective, I took the plus 1.5, plus 1 at 180. It is 6.6, I'll say. But I want a minus cylinder. So algebraic sum of both, plus 2.5, minus 1 at 90. You can see the other axis has become spherical. Then no drug correction, near vision add. Then this is the glass prescription and the diagnosis. These are the 8 steps. If you do this, you will get 85 to 90% of your retinoscopy. Refraction is all about retinoscopy value. Plus or minus, you can have some correction. Do it properly. Learn in your hospital. Do few cases every day, 1 or 2 initially. And all your cases you're presenting. Don't look at the case record and put. Do the vision, do the refraction. It will be great. So there are 2 ways of writing glass prescription. Many hospitals use this. They will write near vision add 2.5. But the ideal way is what we write. You must bring it down, and this is another one, and write the whole thing. This is the ideal way as a PG to write a prescription. This they write, the optician will know, that is okay. But learn to write like this so that it will be clearly understood. Now I've given you three problems. One, all are plus and minus. You know, the problem you were thinking about whether it's a mixed astigmatism or not. All are plus and minus. Plus 2.75 minus 2.5. Plus 2.75 minus 3. Plus 2.75 minus 2.75. Take a minute and think what is the diagnosis for each. Yeah. Okay. Now, transpose all this now. I'll give you a minute. If you transpose all this, okay, you do it later. Plus 2.75 minus 2.5, algebraic sum will become plus 0.25 and plus 2.5 at 90. Now what happens here? Plus 2.75 minus 0.25, it will become plus 3. Here plus 2.75, it becomes 0 diopter. Remember, when the spherical power is more than cylindrical, when you have opposite axis, spherical power more than cylindrical is a compound astigmatism. If the spherical power is less than cylindrical, it's a mixed astigmatism. If spherical and cylindrical are the same, it's a simple astigmatism. Okay. Compound hypermetric, all minus at 180 with the rule. Mixed astigmatism with the rule, simple. Now here you can see when you transpose, both become plus. Am I right? When we transpose, both become plus. So it's compound only. When I transpose also, one is minus, one is plus. So mixed. Here it will become a zero sphere with plus. Simple hypermetropic astigmatism. So this is the way you understand whether it's a mixed or not. Now coming to near vision, there are two ways of calculating. One is age corrected, which I told you. Supposing a person who's a watch repairer or a goldsmith, they come, you don't put by trial and error. So there is a Donder's rule. Generally, there are two Donder's rule. For hypermetropia, we give one manifest plus 1/3 of latent. For a scientific method for near vision correction also is called Donder's rule. So there are 4 points you have to do. You don't correct just like that by trial and error. Calculate what is the available power, calculate what power is needed. So amongst the available power, you have to keep 1/3. Some will say half, 1/3 reserve for stress, fever, everything. You don't knock off completely and correct and give the required power. I will tell you about this in an example. A watch mechanic reads at 67 centimeters. He needs to work at short distance of 25 centimeters. This is an example. So what will we do? What is the available power? If I'm reading at 67 centimeters, using the RAF ruler, I find out it is 67 centimeters. So 100 by 67, I'll have a power of 1.5 diopter. That is my available power. But I need to read at 25 centimeter. 100 by 25 will be, I need 4 diopters. Understood? Available power is 1.5, but to read at 25 centimeters, I need a 4 diopter power. So normal tendency is 4 minus 1.5, I'll give you 2.5. No. What happens is, in the available power of 1.5, you can keep 1/3 reserve. 1/3 of 1.5 is 0.5. Take only 1 diopter. Now what will happen? Effectively, available power becomes 1. So 4 minus 1, I'll give a 3 diopter power. Available power is 1.5. Power needed is 4 diopter. Keep 1/3 of the available power, which is 0.5, keep it reserve. I have eventually 1 diopter and 4 minus 1. I need 4. Already available 1, I give a 3 diopter. This is the Donder's rule for correcting near vision. So I'll give you one more example. This is an atropine patient for 5-year-old. So plus 6.5 and plus 4.75 is the power cross. So what will happen? Distance correction will become 5.5 and 3.75. Okay. 1 plus 6.5 minus 1. Okay. This is done. Next, what will I do? I'll take the smallest power, 3.75. Remaining is how much? We have 1.75 at 180. Correct. 1.75. Then I'll get 5.5 at the 90 degree. Now what I want? I'll transpose. So what will happen? Algebraic sum 5.5. See, the other axis is 5.5. Change this cylinder. It will become minus at 90. So this is what I'm going to prescribe. So drug correction, I'll give -1. So for the spherical, I'll give -1. Near vision nil. So for plus 5.5, I've given a drug correction 4.5. Minus 1.75, 90. 5-year-old able to read it. So don't put add 0 and all those things. The same power, unifocal lens. You're not going to give a bifocal lens. So this is what? Compound hypermetropic astigmatism against rule. This is the main idea of giving retinoscopy and a correction. Ultimately, whatever we do, The manual method is a wonderful method which every postgraduate should master it and keep in touch. Before you give anything done by a refractionist, make sure that it is correct and the patient goes back happily. Make sure there are some corrections. Supposing a 35-year-old person comes and says, I'm a watch mechanic, I'm not able to see near vision. What will you do? You will end up giving +2, +1.5 for reading, which is totally not correct. At 35, you do a hypermetropic correction. That is, you do a cycloplegic refraction. The patient will have a manifest hypermetropia. So you need to correct the manifest hypermetropia for both distance and near. He will be reading wonderfully. Only by 38, 40, he will develop the presbyopia. These are small tips. So these are the small things I want to convey and thank the AOS chairman, president, secretary, and all the panelists here for this wonderful opportunity. I hope I was able to explain something at least for you people to understand. Thank you so much, sir.
Thank you so very much, Dr. Chandrasekhar sir, for this illustrious talk.
Yes, thank you.
May we have the expert panel comment or ask questions? And also, if Dr. Samar Basak sir could opine on
Just a comment, just going back to 40 years back and reading all those days, like it was more of hands-on. The registered those days, no senior registered or RMO used to teach us, and with the hands and those mirrored two mirror and single mirror method. Later on, the strict retinoscopy came. So we have come across all the phases of retinoscopy, and still I believe this is one of the thing every comprehensive ophthalmologist should know, because optometrists, they are doing their job, they are doing good job, but sometime you will understand when you look at the prescription, patient age and other factor, then you will understand probably it is not correct. You need to change this differently. You need to do it wet refraction followed by that post cycloplegic test after 3 days or after 21 days in case of atropine. On those era, really, I enjoyed the whole thing. So please go ahead and you discuss.
Thank you, sir. If I may request Dr. Uma Kulkarni to kind of
Yes.
opine or
Yeah.
ask any relevant questions.
A very nice presentation by Chandrasekhar sir, or a very excellent presentation. I think PGs will be inspired now to understand, transpose, and give a refractive error. I often feel that during exam, when there's a refraction case, the first thing is a fear in the mind of the PG because they feel underconfident. If they ask questions, the examiner asks questions on the dosage of amphotericin B, dosage of bevacizumab, they are quick, they know everything. But when it comes to refraction and a simple transposition or trying to identify the type of refractive error, is it with the rule or against the rule, is it simple or compound astigmatism, the student often gets stuck there, and it creates a little negative impression, a wrong impression about the student. So it's important for students. So I would say they should start right from the beginning, from the first year of their PG days. Start practicing refraction at a very regular interval. Have a logbook. So we in Mysore Medical College, as a student, we used to maintain a logbook, and we used to write all the refractive errors that we have done refraction for. And that would, I think, around 20 to 30 refraction, if you do, the PGs can overcome the fear. And if they do, say, probably around 30 to 50 or 60 refractions, they'll become confident. And if they do more than that, I think they'll become experts in that. So I think it's a very simple task to do it regularly and consistently. So one more thing that I have observed is when the glow is poor, or they say the glow is very dull, they just give up refraction. I think what sir was telling, the brightness of the reflex and the glow is so important that if the glow is dull, first thing is try to put a high plus lens or a high minus lens. The glow becomes brighter in high refractive errors. Don't think it's always a cataract case which is causing a dull glow. It could be a high refractive error. So just put a +4 or +5 and repeat the refraction, or put a -5 or -6 diopters and repeat the refraction. You'll start seeing the better glow, which is better and brighter. and therefore you can continue the refraction till you get the neutralization point. This very nice presentation, sir. Thank you.
Can we have comments or questions from Dr. Shreya and Dr. Rajendra Chauhan, sir, as well?
Yes, I must. Yeah.
Yeah, you first, Shreya, please.
So I must congratulate Dr. Chandrasekhar for wonderful talk, and he has really made the retinoscopy very simplified. And as he said, it's a foundation of ophthalmologist. I would say it is a bread and butter for an ophthalmologist, practicing ophthalmologist, and every postgraduate student must learn. And usually they start at the first year, they are doing good in first year, but when they start doing it properly, they stop doing it, and then when they come to the third year, because of the exam fear, then they, as Uma has already told, that then they get fear of how to do the retinoscopy because of big gap of 1 year or so. So I always tell them, keep on doing the retinoscopy at least at the gap of, not just don't stop it doing that. So you have practice and you can master the retinoscopy. And most of the time I have seen that they depend on the autorefractometer. Whatever reading is there, they will just do the retinoscopy accordingly. Even the subjective test afterwards, also post mydriatic test also, they will do as per the autoref reading. So I always tell them not to depend on autoref reading. Don't do manual retinoscopy is must. You must learn how to do the manual retinoscopy. And when you do the retinoscopy of that particular patient, call that patient for the post-mydriatic test on your day, so that you know what I have done, and get it checked by some senior person. So you know where I have done whether the neutralizing point was correct or not. And they are not biased of the autorefractometer readings. So these are few things which we always tell them. And always we start, whenever they are beginning for the retinoscopy, when they start doing it, we always tell them not to select for a too old patient or too young patient. Just take a clear media so that they can get the glow, they can appreciate the glow, and they can appreciate the movement of the glow. So these are few points, and Dr. Chandrasekhar has put really very nice few examples of how to transpose and how to very simplified manner. Again, congratulations, Dr. Chandrasekhar. Thank you.
Dr. Chauhan, sir.
Excellent presentation, Dr. Chandrasekhar. It is spellbound. In fact, I wrote down so many things which probably I was not teaching. So it was an eye opener, making a retinoscopy, which was a very, very simple topic. You made it very interesting, in fact. And if the students are listening to this, I think this is an eye opener, and people will create interest in retinoscopy. I totally agree with Dr. Samar Basak, because when I did my residency, we used to do retinoscopy and refraction in the refraction room. But these days, the things are changing very fast. No PG student go to the refraction room. They don't do retinoscopy. They don't do refraction. They feel that this is below their dignity. And I'll tell you, actually, retinoscopy and refraction give you respect, because the refractionist will start respecting you because you know the refraction. And sometimes when you correct it, like I remember one incident where, nicely done at that time, intracameral cataract surgery were done in 1988. One nicely operated patient did not have 6/6 vision, by the best refractionist. So I went myself, because that was the father of my friend. And I did do retinoscopy with Priestley Smith retinoscopic mirror. And I found that the acceptance should be around plus 14 diopter, plus 2 diopter cylinder. And the patient has 6/6 vision. On that day, I realized that you are the best person to do retinoscopy. And if you know the retinoscopy, you can teach retinoscopy to the residents. We have BSc optometry. So if we do not know refraction, they will not respect us. So that is the basic fundamental learning step of all the resident. They must learn to do retinoscopy. They must learn to do refraction. And in fact, he has told everything almost. There is nothing to add. Whatever he has told, it is not written in the even in the books. Dr. Khurana has written a big book, Optical Refraction, but I could still feel that I should write down some of the points which Dr. Chandrasekhar has taught us. And I tell you why the residents are not doing refraction, because they do not want to purchase stick retinoscope, which is costing around 30,000-40,000. They should buy Priestley Smith mirror. This is costly only 200 rupees, and start doing. So everybody must do at least 2 to 5 refraction daily, and that should be part of the regular medical clinics. So I think this should be essentially, and we as a teacher, it is our duty to incorporate faith in them and tell them that if you learn from the, I mean, it is like जो रस्से खींचते हैं वही जहाज के अच्छे कैप्टन बनते हैं. So you should learn these basic things, then only you will become good ophthalmologist. Good, well done.
Just a comment that along with the retinoscopy, we also learned the application of pinhole, because that comes hand in hand, side by side. When we are not getting the 6x6 like that, then pinhole comes. So pinhole is also, many people do not know what is the importance of pinhole along with retinoscopy or refraction or media opacity or retinal central retinal problems. So those they have not done. So they cannot correlate the media opacity with the like cataract evaluation, that this cataract cannot have this vision. Those idea will not come unless they do pinhole along with refraction proper. So I always tell our junior fellows that you do refraction, optometrist also, you do refraction, and at the end, you must write the what is the pinhole visual acuity. That is our target also. So something is wrong somewhere in the media opacity. So, and pinhole size is also important. Those days, Abraham was the book we read actually. You can remember Duke Elder Abraham, a small book, and that was actually our Bible in those days during our residency. So, thank you so much, Chandrasekhar.
Thank you so much to the expert
Thank you,
panel
sir.
and Dr. Basak for the comments. We now move on to Dr. Pratik's talk, and I shall be introducing Dr. Pratik. Dr. Pratik is an MBBS from the Veer Narmad South Gujarat University and also hails his master's from the same university in a medical career with education spanning from 2003 to 2013. He has a diploma from the Royal College of Edinburgh and a fellowship in the phacoemulsification from the Medical Research Foundation, Shankar Netralaya, Chennai. He is currently serving as a senior consultant, Vitreoretina Services, Ophthalmology Department at the Kiran Multi Super Speciality Hospital and Medical College, Surat, in Gujarat. And today he shall be opining on optics and basic principles of ophthalmic diagnostic instruments. Over to you, Dr. Pratik.
Hello, thank you for that nice introduction. And I'm actually thankful to Dr. Chandrasekhar sir because basic refraction includes certain principle of the refraction, and that actually makes my job little easy to make the optics of certain basic ophthalmic instruments easy to explain. Now, first, the instruments I want to cover here is an indirect ophthalmoscope, OCT, angiography, obviously our basic instrument, that's a slit lamp, and ultrasound if time allows, and because it's not properly an optical phenomena, it's acoustic phenomena. So let's move on. First, I choose the indirect ophthalmoscope. Actually, the slit lamp was my first topic, but I choose the indirect ophthalmoscope because with certain principle of the retinoscopy actually helps in better understanding of the indirect ophthalmoscope. So we are directly moving to the indirect ophthalmoscope. It is one of the very important instrument which helps in examining the complete retina from aura to aura. But why it is called as indirect? Because we are not directly seeing the retina. We are seeing an image of the retina that is formed through the condensing lens, and where that image is formed in between the lens that is held by the observer and it's an image of the subject's retina, and that is between the lens and the observer's eye. So basically, it has one key part, that's illumination system. There is another part, that's a heat support system and reflectant part. But more important here, if we will see, when we are understanding the optics, here is that is something which is a condensing lens. Here the image is formed between the condensing lens and the observer's eye. And this image is then, with the help of these mirrors and prisms, divided into the two and goes for the right eye and the left eye of the observer, which provides us this stereopsis. And that is one of the very important point. Now, if I will go in little more detail, then actually this is how it works. Basically, there is a area of the area of the subject's retina that is illuminated, and that illuminated retina is reflected back through the subject's pupil onto the lens through the optic phenomena of the subject's eye. So here one optical phenomena, that is of the subject's eye. That the optical phenomena gives the image of the illuminated retina of the subject's part. Now, this illuminated retina of the subject's part, with the help of the condensing lens, which we are holding in our arm, with that, we are trying to focus that on the subject's retina. But in between, what happens, that this image, with the condensing lens, reaches to the indirect ophthalmoscope, where this image is divided for the both eye, right eye as well as the left eye for the observer. And this both eye, with the principles of the condensing lens, this image will be the inverse laterally as well as upside down. Now, basically, so one image that is created, patient's eyes, patient's illuminated retina, image is created, and that image is divided into the right eye and the left eye. And finally, both images are fused by the brain, and that gives us the stereopsis. In the real life, for the better understanding, here is the actual thing. This is your illumination system through which it goes in, reflection with the help of the mirror, prisms goes into the subject's examination. So this is the illuminated retina of the subjects. So here there are, at the patient's pupil, there are three things. First, illuminated light beam and reflected light beam. So basically, to have to do a good indirect ophthalmoscopy, basically two principles, and that were originally a principle given by the Gullstrand. What exactly it says is that in order to obtain a binocular view of the fundus, to make the use of the available illumination, three images must be located inside patient's pupil. What it indirectly says that a patient's pupil should be adequate enough to accommodate all the three images. Two dissimilar images of the illuminated retina of the patient and one our illumination beam. Now, second thing, that is again very important thing, in order to avoid the bright corneal reflections and the reflections from the lens, the distance between the two images and the light source should be adequate enough with the patient's pupil size. Means if patient's pupil, and that is exactly what makes us understand that why we are having a different aperture of the illumination in the indirect ophthalmoscope. So if you will see, when we are having a full dilated pupil, we are using the largest aperture. If the semi-dilated pupil, we are using the middle aperture, and there is no dilation. And even in undilated pupil, if we try to look with the indirect ophthalmoscope, there is a smallest aperture with which we can still try. Why? Because if by we are reducing the aperture size of the illumination beam, that again reduces the size of the reflected beams. The space between the two images, as well as all three, should be accommodated in the patient's pupil for the complete better binocular depth percepting the proper image. So these two principles are very important if we are doing in practical life this. This is actually how it happens at the observer ocular's level, and this is at patient's pupil level. Now we are moving on image magnification. What is the image magnification which we are going to receive with the indirect ophthalmoscope? So in a routine life, for the simple understanding, what we say is that reduced eye constant of an eye, human eye, is around 60 dioptric power. So in a simple way, for without going into the very difficult calculation, we simply put it, divide the total reduced eye power of the human by the power of the lens. So what is the 60 dioptric power is a human reduced eye power that is divided by 20 dioptric lens, which we are going to use to gives around 3 times magnification. In fact, if you are using the 14 dioptric, then that changes, and that is how it works by and large. Now, how is our lens should be? And if I will say that if we are using the 20 dioptric lens, that is the most commonly utilized lens. So if this 20 dioptric lens, that is a complete 20 diopter on one surface? No. It is divided 3:1. The front surface or the surface which is towards the observer, or that is, should be towards the observer, should be the more concave surface that carries approximately 15 dioptric power. And the surface which is towards the patient should be the lesser concave surface plus 5 dioptric power. And that is how the lens power is adjusted. Why all this is required? Why can't we make simple 20 at one side and plano at other side? Or why can't we make simple 10 equal on the both sides? Because this is very important to keep the instrument, or to keep the lens more user friendly as well as reflection free. Like for example, if I'm making it at 20 dioptric at one surface, it will give me a good image which is the reflex free only as it is holded absolutely perfectly. Means, yes, your skills will only required. So during the initial period, if you are not able to hold properly, it will give significant amount of the reflection and some kind of the discouragement. So this is one of the important things. If we will make 10 on each surface, there's a very high amount of the reflections in spite of the properly holding. So 15 into 10 15 by 5 is the one of the best way of utilizing. Nowadays, current lenses have again the marking surface which we can keep towards the patient side, and that is actually the guiding way. So that is again one of the clue for the students to hold it. How should you hold it properly? In optics of this lens. Okay, so this is all about the indirect ophthalmoscope and the lens which we are going to utilize. Now the next instrument I'm moving towards is the OCT. That's ocular or optical coherence tomography. So basically it is an optical, so basically we are going to utilize the spectrum of electromagnetic wave. That's why it is known as optical. Coherence because it is a wave characteristic of the waveform. We are going to utilize the low coherence light. So it's a coherence. Tomography because it's a cross-sectional study of the surface of the retina. So that is how it is a tomography. Now, what we are going to use is it's a low coherence interferometry. And basically, interference is the principle which we are going to utilize with this OCT, and that's why it is known as interferometry. Interference can be of two types. One is constructive and one is... And basically, how can it is going to helpful? Because the surface of the retina, the ILM and the RPE, between these two thicknesses around 300 micron, and because of this, the reflected rays back to the spectrometer have a little lag or different time interval, and that is how it works. Now, basically, when there is a light through the OCT, which is thrown, that is going to divide it into two. One will go to the subject's retina, and another will go towards the reference mirror. Now, reference mirror, we know it's a standard thing. It is a fixed distance. So the light reflected back reference mirror, and the light which is going to reflect it back through the patient's retina. Both are compared. Now, basically, here that optical property of the eye, especially retina is a tissue. It has the nucleus, it has the cytoplasm, and all those tissue property is going to add the noise. And that is how, and especially when pathology is again present, like for example, CSR, there is additional amount of the fluid, there is a cystoid macular degeneration, if there is a blood in the CNVM. So those all add to noise. With comparison of the reference and this noise, we can make exactly the proper image. When we are looking at the OCT, I thought these are the these all optical principles. One of the very important thing is, like, if we know that it makes our life little easy, they are most of the time the behind the curtain players. So in day-to-day life, directly we are not using them much, but yes, one of the key form which we should know is the zero reference line or zero inner line in the OCT. What it is, like what I said, one ray is going to go towards the reference line. So for the reference mirror, so for that reference mirror, to identify that in a retina with a baseline, and that is exactly the reference line of the retina or the zero reference line of the retina. In normal SD OCT, the zero reference line or zero delay line corresponds to the ILM, internal limiting membrane. But nowadays we know spectral domain OCTs are again have deeper penetration, and they are also utilized for the enhanced depth imaging. So for the enhanced depth imaging, if we are using the spectral domain OCT, if you know in a practical life, we switch one mode from the EDI mode, and that EDI mode shifts the zero delay line from ILM to RPE for the better penetration. Why this? This is one beautiful principle they utilized. Now, because when we were keeping that zero delay line at ILM, still we were able to see some part of the vitreous which is anterior to this ILM. So what they did is, if we keep this line at the RPE level, then that anterior part of the retina will be scanned because of that. But even with that, we can see the choroid as well. And now with a newer machine, which the swap source OCT, the zero reference line is still at the ILM only, and but with a deeper penetration of these laser lights, we can see the choroid. So this is the one OCT which is taken with a spectral domain as well as the same with a SS OCT. This is a swap source OCT where we can see even the sclerochoroidal junction as well. These are the different layers of the retina, how it appears with the help of the OCT, and more importantly, certain new nomenclature. Like for example, previously what we used to say is that ISOS junction is now more commonly said as the ellipsoid zone, and previously the line which is known as the cost line, uh, that is basically intermediate zone. Now, one important thing is in the retina, when we are interpreting the OCT, there are three constant line, but three constant hyperreflective line, which we should know. One is the RPA-Brooks complex. Second is the cost line. Yes. So this is your RPA-Brooks complex. Second line is the cost line. Third line is the Z. And after that, fourth constant line is the external limiting membrane. These are the layers which are hyperreflective and hyporeflective. So basic understanding, we should know that whenever there is a plexus, one is ending with another, that causes more amount of this scattering of the light. And because of that, the plexus gives hyperreflective. So inner plexiform layer, outer plexiform layer, or wherever there is a junction, that gives hyperreflective. Whenever there is a cytoplasmic thing, so basically the nuclear layer, ganglion cell layer, so these are more like a hyperreflective area. Pathology, if we will see, similar way, if the fibrosis like the epiretinal membrane, blood exudate blood or fibrin, or vascular proliferation, or fibrous tissue, pigment proliferation, drusen, these all appear as a hyperreflective. But while there is a fluid, like for example, intraretinal fluid, subretinal fluid, serous PED, that will give like more a hyporeflective. Even degenerative cell loss in IFT or IJT or PFT, that is again hyporeflective. And yes, loss of that so-called ISOS junction or is that ellipsoid line that again may appear like an optical clear space. So this is all about the OCT. Now, if I'm moving towards the third modality, that's a fundus fluorescent angiography, which is as of now still day by day reduced in utilization because of the better availability of, but still it is one of the very important thing to understand vascular changes, how it is going on inside the retina. Especially many times if we are seeing something means blood hemorrhages and we are not getting any clue why this is happening, what is happening, what is actually, then to understand the vascular flow, this angiography is one of the very important things. So how basically angiography works? Very simple. Fluorescent is a property of one chemical molecule. We are injecting this fluorescent chemical inside the blood. This, with the blood flow, it reaches into the vasculature of entire body, including the eye. First, it will go to the choroidal. and then the retinal circulation. Now, so what happens basically inside the retina, inside the blood of the retina and the choroid, the dye is kept. What we are doing, we are putting one light that excites this dye, activates the dye inside this blood. And when this dye is excited, it is going to reflect back the light. Now, what we are going to do with an appropriate filter which catches this reflective light, we are going to catch that. So, what basically we are going to see is not anything else but what the dye which is moving everywhere along with the blood flow. So, what exactly this fluorescent angiography is, the dye, we are going to follow the flow of the dye which is moving with the blood flow in the coronal and the fluorescent choroidal as well as the retinal circulation. So it has a excitation spectrum and the emission spectrum, and that is how it is going to work. Now, there are two types of the angiography. When we actually started studying, we had only this digital flash, which was lesser in a detail of the discrimination. And then the more finer version, that is a confocal staining laser, that Heidelberg imaging system, which we call a CSLO system, that is the confocal system. Now, why these two systems? Because again, here, very important principle of the optics, that's a diffuse dispersion. With a flash camera, what we used to do, there is a beam of the flashlight which was exciting this dye. Now, with the confocal system, what we are doing, the diffuse light, we are making it a small aperture, and that smaller aperture will make the reflectant light even very small, which gives us more finer detail or more better clear detail. So basically, what we are here doing with a confocal system, it is just only we are doing removing diffuse dispersion. So exactly here again, let's move. What are the advantages, disadvantages, why this is better? Like yes, what I was telling, resolution of the image here up to the 5 micron details we can discriminate. While in the digital flash 15 to 18 or approximately 20 microns in a roughly we can say. So obviously the flash intensity which is required is much more in the digital camera. While confocal system we are even making the aperture into the very smaller fine aperture. So we are definitely reducing the exposure of the light. So patient friendly will be definitely, because laser flash dynamic study is not possible with a diffuse because the poor discrimination as well as the time frame is lesser. Here more frames is possible, details are more easily discriminate. So usefulness in a difficult challenging case like a patient if has a head nodding or squint or nystagmus and having a retinal issue, if we are having a confocal, it is better. And obviously, what I said, patient experience with a lesser light will be always better, more better images. So yes, when we are interpreting this, we have to understand that time frame is something important. When we are doing angiography, we are going to understand the dynamic study. Blood flow is not something which is a constant, and we are continuously going to study the how the blood flow and how the dye with the blood flow is going to move. So in case the dye is leaking somewhere, that area will give you the hyperfluorescence. So if there is a blood retinal barrier leakage, so you will get a focal area of the leakage. For example, there is a PED, you will get a hyperfluorescence. But if that is a limited space, that will be remain constant. Now, apart from that, more importantly, in CRAO, there is arm to retina circulation time. But dye, how speedily it reaches. When we are injecting the dye in the arm, and first click we do, and first time it appears into the retina. So this is how the arterial phase appears. This is the first appearance of the dye inside the artery system. Then AV transit time. First dye reaches to the artery, and then when it appears the first in the venous system. So that is the arteriovenous transit time. And that is exactly how it looks like this. Here, if you will see, the dye is filling full arteries, but early laminar flow in the vein. It is exactly how the AV transit time is conducted. After that, the full veins are filled with a dye. But later on, this dye starts getting vanishing off with a constant blood flow and the excretion system. So there is a continuous dilution of the dye. That is something which is considered as the late phase of the angiography. Right? So this is all about the basic principles of the angiography. Now, if I'm moving towards the one most commonly utilized instrument, that's a slit lamp examination. This is one of the very important to know, because that is something like a bread and butter. What we were saying, that after the refraction, if we are going to do something with a patient is going to examine the eye, and that is the most commonly utilized instrument is a slit lamp. Why we were in need of this slit lamp? Because originally when I were examined with a torch light, the principle was a diffuse dispersion of the light through the torch, in which minor details we cannot see. To see the minor details, particle in the tissue should be lesser than the wavelength of the light. And each particle in the tissue act as the starting point of the new light ray, which spread in all the direction and interfere with each other. So that is what exactly we used to say, that scattering, and that is causing the loss of the details that is present in the cornea or sometimes lens and the vitreous. So basically what the slit does, slit reduces this diffuse illumination into this smaller focal illumination, and that actually gives us a better details. So basically, if we are looking at a slit lamp, it has one observer's area, and this observer's area has a telescope which works on the astronomical principle or astronomical telescope. There is another unit that is, so this is your illumination system, and this is your observer system. And this observer system is based on the astronomical system. And this is again the on the Galileo's system. Now, more importantly, what we do is that how should we examine and how should we use the optical principle of the light in a day-to-day life? So one most commonly seen is a diffuse illumination, which broad flow of the light, we can see whatever, everything we can see. But here minor details will be missed. So for the minor details to be seen, oblique illumination is required. What we do the oblique slit of the light, in which the surrounding, very narrow surrounding area can be seen through this oblique. It's something like taking the optical cross section of the eye. We can see how is the corneal thickness, how is the length, whether cataract is there or not, and all those things. Yeah, unfortunately, this is one of the most commonly system which is utilized by most of the students. But more importantly, what we should know is the rest of the things. Now, what is the next? That is so this is how it works. Cross section of the light, which gives us the detail of the surrounding area. Okay. So now we are moving towards the third system, that's a retinal illumination system. How it differs from the rest? In the rest, first and second, what we are going to examine about the eye or the tissue is a directly illuminated area through the directly thrown light or projected light. Now, this is not something like that. Here, what we are doing, we are throwing the light. That light is illuminated the surface, and that from that illuminated surface, there is a image which is projected, or that is the light which is the projected reflected. And in front of that reflection of the light through the tissue, we are observing the micro details. So that is exactly the retroillumination. Now, what we can utilize? Only non-transparent surface can be utilized for the reflection or for the retroillumination. So inside that, we are having retroillumination at the iris. When iris we can utilize for the reflected backlight, or the retroillumination of the posterior pole or the retina, means in front of the red glow of the retina, we can see the retroillumination. So here in the image, we can see the retroillumination through the retina and retroillumination through the iris. So here, if you will see, more importantly, here nice network of the blood vessel on the corneal vasculature, we can see how deep corneal vasculation has been taken place. Now there is a sclerotic scatter. Now, if we are looking at a sclerotic scatter, what exactly we are doing? Here actually the 4 mm slit we are going to use. For the one limbus, we increase the light illumination to the full. In the first 3, we keep it light illumination which patient can tolerate, but here we can make it full. We make the illumination hand around 60 degrees, and through that we reflect the light at the limbus, through which this light travels to the thickness of the cornea. Now we are utilizing the corneal tissue depth. And just like the fiber optic, how it works, the light which is reflected passing through these cornea reaches to the other side, and the other side, and this other side is getting illuminated. So that is how this sclerotic scatter works. And the last but the most important, that's a specular illumination means 45 degree throwing the light, 45 degree we are catching the reflection of that light, and all this 45-degree reflection make the surface through which it is reflected very clear. And that is exactly where it is utilized for the endothelial health. So we may find it little challenging, but if we will go through practice and all, then we can definitely see certain corneal endothelial pathology with this specular illumination. And if I will just brief ultrasound for the completion of the talk. So ultrasound is something which is acoustic phenomena, works exactly on the reflection of the light wave only. There is one light which is original sound wave passes through the tissue, and according to the tissue acoustic characteristic, it passes reflecting back, and we are capturing that. Captured signal are amplified with the proper amplifier, and after this amplifier, that is actually interpreted. So basically, piezoelectric crystal, which is important thing in the ultrasound, and that is how exactly it works. And there are different tissues and different acoustic impedance, and according to the different acoustic impedance, the reflectant works. So basically, this amplification process is again of the three types. There is a linear, that log, and the sigmoid shape, which is a combination of the linear as well as the log. And final images basically is the formation of the dot. So basically, what is the more important in ultrasound is lens, which is generally it is a echo-free if it is a clear lens. But if it is a attractors lens, it may have attractors echo. Generally, the posterior surface of the lens, that PC capsule, what we can, or PC is very well seen even if it is a clear lens. So intralesional echo are generally not there in a clear lens. IOL will produce the reverberation echo. Vitreous is generally echo-lucent, or few vitreous degeneration causes few low reflective dot echoes. RCS generally appears as a single reflective high reflective structure, and this is how the posterior capsular echo in the normal lens, the RCS complex, the translucent or echo-lucent vitreous, and this is how in the tractional retinal tabletop RD or tractional retinal detachment it appears. Optic now generally appears as a wedge-shaped acoustic void. Orbital fat will have a high reflective, and ocular extraocular muscles appears as the echo-lucent. Thank you, thank you, and thank you, AIS, for giving me this opportunity. If any questions, I would be happy to take those.
Thank you so much, Dr. Pratik, for such a wonderful talk and putting all the diagnostic instruments in a comprehensive manner together. May I now pass over to Dr. Uma, Dr. Shreya, and Dr. Rajendra Chauhan for their expert comments and questions to both the speakers for this evening.
Yeah. As rightly said by Dr. Shah, I think we need to use all the types of illuminations that are required in the slit lamp, that are available in slit lamps, say direct. Don't go only by oblique or direct. We need to do trans illumination. We need to do retro illumination, depending on the case, so that we are able to get the a good view of the findings. It's very, very important. But one more thing about refraction that I would like to say is about refraction in children. Sir, Chandrasekhar sir, would you like to share your experiences of refraction in children? Because it's really very difficult to have the child sit there, and we need a lot of patience. So would you like to say something about that?
True, madam. So the ideal method for refraction in a child is cycloplegic. Very young children, we do atropine, and then we move on towards cyclosin and so on. But too young children, now the optometrists are specially trained for managing pediatric ophthalmic cases. For the mother is there, they can do. Otherwise, if too young a child, then you have to do it under sedation and the auto ref and the theater only. But the ideal would be to do a perfect cyclorefraction, and better not to take a risk at the first time at all. For further follow-up, also ideally 4 to 6 months, 3 to 6 months, depending on the age of the child. So, and the correction also, there is variation between an adult and a child, where we undercorrect sometimes and we have to overcorrect. So best thing is for a pediatric ophthalmologist to decide what is the best power to give. But the optometrist will do a good job, but it is not like an adult. Actually, it's a bit of a challenge for a general ophthalmologist to do a young child. Grown up 8, 10 is okay. Yes,
And
We
you
ma'am.
are
and
correct.
you have to have patience to examine these patients, young patients, children, because they move, they don't keep the eye straight, steady. So you have to have patience to do this.
True,
Yeah,
madam.
one more thing about cycloplegic refraction in children is one experience I would like to share is a child was brought to the OPD and we were planning to do cycloplegic refraction because we were suspecting hypermetropia and astigmatism. And after instilling cyclopentolate eye drops, the child started behaving slightly abnormally. So psychosis is one of the side effects which is seen in cyclopentolate. So it's very important to have do punctal occlusion so that systemic absorption is reduced. At the same time, also look for the warning signs and speak to the parent, mother usually who accompanies the child, so that you can handle these situations in a warm and nice way.
Absolutely, madam. Absolutely. That's why I think previously we used to give atropine ointment,
Yes.
where only fever could be the problem. But the drops can cause systemic
Yes.
absorption. And actually, it will be scary for the parents. We should warn them also.
Yes.
Yes.
Dr. Pratik, may I speak?
Yes, sir, please.
Dr. Pratik, actually, it is a condensed capsule which you have told everything in half an hour. It is very, very difficult because the topic is so lengthy. In fact, what I used to tell my residents that ophthalmology is 90% medicine and 10% surgery. So, what 90% medicine is? All these investigative procedures. So, these investigative procedures are so important that if they master these procedures, then 90% of the diagnosis they can come to a conclusion. So, I think it was not justice given to you to cover all these topic in half an hour. I think every topic needed half an hour. First of all, thank you so much for condensing everything. And regarding
Thank you,
the
sir.
indirect ophthalmoscopy, actually there is an article in Survey of Ophthalmology and by Boyd. So that article says that you should spend at least 60 hours to come to the explanation of indirect ophthalmoscopy. So until unless a resident has spent 60 hours doing indirect ophthalmoscopy, then only he will master the indirect ophthalmoscopy. So that is first thing. Second is, I always tell my residents that the basic fundamental of modern ophthalmology is that you must see all patient on slit lamp, you must operate all patient under microscope, you check all the IOP with A pleasant tonometer, and you should do all fundus by indirect ophthalmoscopy. So these are the four basic fundamental. So all these, out of them, indirect ophthalmoscopy, slit lamp, you have already covered. Microscopy and aplanation tonometry are still left. Regarding slit lamp examination, actually, they should see patient by torchlight examination first before they put the patient on slit lamp. I had been going for MS examination almost everywhere in the country, and I found that MS candidate, DNB candidate, they miss the diagnosis of exotropia or esotropia,
Yes.
and they tell everything on slit lamp examination. That is one thing.
Absolutely, sir.
And
Even sometimes the DCR swelling, that swelling, scar mark, or even that gross lid pathology also, sometimes they directly put the patients on slit lamp. They go to the
yes,
slit lamp, they completely miss all those major out.
exactly. And actually, what they feel that slit lamp examination is an examination of the cornea only. It is not like that. Slit lamp
Perfect.
examination means diffuse examination under low magnification and diffuse examination, so that you see the periphery, you see the adnexa, and then you go to the higher magnification and scan the epithelium, then scan the stroma, then scan the endothelium, and then scan the anterior chamber, and then scan the lens and give the cut section 45-degree retroillumination. So all the five methods what you are telling are actually very good, and they should once they sit on the slit lamp, they should use all the methods. Number one. Number two, they should have one gonio lens in one pocket and 190D in another pocket. The moment the patient is on slit lamp, even if it is not dilated, they must see the fundus by 90D or 78D, single, one go. And if they feel that anterior chamber is shallow, they should do gonioscopy as well. So that means every patient need at least half an hour, right? In due course of time, once they become expert, they may finish in 20 minutes or 15 minutes. Second is that these the children are not checking the aplicant, that aplicant tonometry is part of the slit lamp examination only. The moment they see patient on slit lamp, they must check the IOP also if the patient is more than 40 years of age, so that they cannot escape that I have not checked the IOP, or I did the digital only, because that is easier, right? Or I did NCT. Even in the exams, when I ask, why did you do NCT when you are doing slit lamp examination? You could have done aplicant Now, 90% of the residents do not know how to do aplicant and 50% of the residents do not know how to do indirect ophthalmoscopy, because everybody is targeted now on surgery. That's only 10% of ophthalmology. So, and the third is OCT. The OCT, because fundus fluorescein angiography is now almost obsolete because of the OCT. Nobody is trying to do fundus fluorescein angiography, although fundus fluorescein angiography is still indicated in certain cases, not all. But because it is invasive procedure and because anaphylactic reaction can occur, that is why people have stopped doing fluorescein angiography, because you need a crust trolley, you need anesthesiologist, you need every drug along with the patient. And then, of course, you should be able to interpret it and you should be able to take all the photographs. And I bet you ask only simple question, what is the time span from arm to retina? 50% of the residents are just unable to answer this question, right? Even the simple full form of OCT, you just go and ask. They do not know what is the full form of OCT. They say this is optical computerized tomography, right? So these are some of the things that one of my junior colleague in from Bengal, he used to say, Dada, we need to read from cover to cover. Means from first page to last page, you should read everything. So everything is important. They will read, they will just see OCT and they will read everything about OCT, but they will not come to know what is the full form of OCT. And B scan,
That's where
of
I feel
course.
that this attempt of the AIOC, if they will listen even this type of the activity, then even in such a small time, they will able to learn a lot. I think this
Actually,
highly
look,
appreciable effort by the iOS.
actually, this is the time when they are very lucky that they are listening to the pan-Indian teachers.
Absolutely.
Actually, people are all from all over India. Everybody has got different experiences, and these are the experiences they should learn. Because when they are resident, they feel why they are just bent upon that go to the refraction, go to slit lamp examination. So in my institute, I made it a habit that I don't see any patient without slit lamp. And I tell them that you need to see patient on slit lamp. Come to me only after you have examined everything. Don't just call me and कि sir इसको देखो बताइए क्या है इसमें. No, that is not the idea. The moment I ask what is the vision, they do not know the vision. The moment I say what is the IOP, they do not know the IOP. And then the moment I say what is the fundus examination, oh, that I have not done. Slit lamp means only cornea. No. Slit lamp means IOP by ablation and in the fundus examination by 90D. So that is complete comprehensive slit lamp examination. And I think you have covered almost everything. And in fact, I think every topic need a half an hour. Thank you very much. Done good job.
Thank you, sir. Thank you.
Sir, with your permission, can I add a point?
Sure, sir.
Sir,
Sure.
for a PG, you said rightly 90% is knowledge and 10% is surgery. But today, before going for counseling, they call up all the hospitals. How many surgeries I will get?
Yes.
What all surgeries I will get? Only that is the
Yeah.
deciding factor for them, sir. But
Absolutely.
actually, without the base, they don't know. Thank you, sir.
Sir, I always tell them, if you make the correct diagnosis, you should be a good clinician first, then a good surgeon. Because if you make incorrect diagnosis and do surgery, the result will be very poor. For example, if the patient is having chronic congestive glaucoma and you think it is only cataract, you operate, you expulsive choroidal hemorrhage, right? So, I mean, you should be able to make the correct diagnosis first. And this is what Dr. Gullapalli Nageswar Rao used to say, that you should be a good clinician first, then a good surgeon, because surgery is nothing but carpentry. You will learn in 1 month. But to make a good diagnosis, you need to put a lot of time. Hello, sir. Good evening, Dr. Manoj Mathur, sir.
Good evening, sir. Manoj,
Good
sir.
evening, sir.
So
Please carry on, sir.
I think Dr. Pratik has taken, he has really worked very hard to compile all these optics in various equipments, optics in really half an hour. I do agree with Dr. Rajendra ki it was not an easy job. Very nicely, and especially I like the line diagram of the optics what he has shown, because many times postgraduate students they get the they have to draw a diagram for the optics, they get the question about the optics, and it was really very nice so that they can just draw what you have shown. And about the 20 diopter also, the way you explained, it was really, I think they will be benefited by the, now they can hold the lens in a proper position to get a good view. Very nicely present, especially with the slit lamp also, it was very well explained. I think it was a very nice presentation.
Thank you, ma'am. Thank you.
Yeah, with the kind permission of all the panelists, I do have a few questions for Dr. Pratik from my own colleagues who have been listening to this on YouTube as well. So they've asked the how would you put across the use of indirect ophthalmoscope in screening of neonates or premature infants in ROP, and what are the do's and don'ts when handling a neonate or a premature infant with respect to not only examining the child per se, but also giving due respect to the family around.
So that's one of the very good question. So here I'm almost doing 30 ROP screening. I'm sitting in one of the multi-specialty hospital. We have our own in-house neonate. So I'm happy to definitely answer this question. There are first and foremost thing I would like to say is that a good coordination between the pediatrician and you. First screening has to be there somewhere between the third or fourth week, late by late. When we are examining in NICU, we can always inform the patient's parents priorly that we are going to do this test and why it is required, because it's one of the very crucial thing. If they know, then only they will able to come for the follow-up. We should complete give proper emphasis on the child time, especially in explaining this. In case I'm doing this ROP screening in front of in my OPD, then first thing I would like to tell them is that, okay, see, adult as an adult, if I have to examine your eyes, I will tell you to open your eyes. I will tell you to look right, look left, up and down. You will able to do all this and you will able to follow my command. But when I'm going to do it for the neonate, neonate won't able to do that. So for that purpose, to open their eye, I am going to use these two instruments. To move their eye right, left, I'm going to use this instrument. And maybe will cry a little bit and you should not worry. So that will make little initial rapport with them, and that will make them little comfortable that, okay, baby is going to cry. And but this is very important examination. We are practically trying to help the baby, and it is very mandatory. So this initial 1 minute of the conversation, I always try to do with each and every patient which is entering in my OPD for the ROP screening. Apart from this, during the indirect ophthalmoscopy, if I will tell, that proper adjustment is very important. So one very important clue I would like to tell is that a table height. Table height should be somewhere at the waist level of the examiner, because when we are doing the indirect ophthalmoscopy, remember, it is a skill and we have to examine up to the aura. To make this possible, use the table height is at your waist level. It will be very easy for the patient's periphery, your length and subject size, all these three to align in one line and to make a proper examination. So make the proper table height, make yourself comfortable, make the patient comfortable, and then again, I will again say that indirect is again one of the skills. So your flexibility is again very important. Your movement at the torso level is again very important. So you have to bend in a way with which your lens and the patient's eye will again come aligned properly. Now, third thing, how to hold the lens is again one of the very important thing. What we discussed was actually the focus with the optics only, so I couldn't tell it that time. Now, the lens should be held ideally in a way that I will just suggest that this is your arm, right? This is your wrist. So you have to put it like this. Your little finger is resting on the forehead of the patient, and this ring finger is again there. With the help of this uh, index finger and the thumb, you hold the lens. With this finger, you retract the upper lid, and then with this movement, you are fine focusing the lens. So that is one of the very important. This fine focusing of the lens is very important. Why? Because with that only, our goal is to get a complete round circular image inside the lens. Means image should be filling the full lens, the complete round image during the indirect ophthalmoscope. It should not be the half lens is filled with the image, half is with the reflection. It should be complete. Your entire lens area should be filled with the image. So that is again one of the very important fine handling of the lens. And apart from that, proper adjustment of the headband is something very important. There is one inclination knob that will help you to arrange the optical part of the indirect in parallel with your limbus so that you can have a proper imaging. So I am sure this will answer. In case anything more you want, please ask.
Pratik,
I want to
just
say
a
something.
request. Can you make videos of all these things, whatever you have said, how to hold the lens and how to,
Yes,
that will be really very good learning for the postgraduate. The way
Yeah,
you are
sure. I will
explaining
make
is
a video and even I will have some diagrams. So next time, even in the PPT also, I can try to
yes,
show.
yes, you can add
Actually,
the,
ma'am, this is actually very descriptive. What sir was telling is very right. That in actually, I had a full 1 hour presentation in Shankar Netralaya during my Retina fellowship. I did, and my first presentation was optics of the indirect, and that 1 hour class I had given on this. So yeah, I understand what, but this part I focused only with the optical part only. So yeah, I will definitely try to include in interest
yeah.
of all and completion of the
Uh,
topic.
I have certain point to add.
Yeah, please, sir.
Uh, in ROP screening, actually, when you are going to NICU, you should have a dedicated room for ROP screening. Number one, and the ophthalmologist should also wear the gloves. He should wear the cap and mask, and the assistant or the nurse or the that pediatrician, they
Absolutely,
should
sir.
also wear the same thing. Number
Because
one.
neonatal septicemia and everything is very common, so
Yeah.
we actually change wrap ourselves
No,
in a gown.
sir, you might be in a very good center, but I am talking about all of India.
Yeah,
Okay,
absolutely.
so that is a must because these children can get infection.
Yeah,
Second is that even the 90D, oh sorry, the 20D and 30D lens should also be ETO sterilized. And after once you have seen everything, you can come out, make a diagram, and explain to the parents
correct.
that this is the situation, and you need, because this is the situation of the baby's eye, so you have to take it seriously and come for a follow-up. The baby might have normal vision later, and if nothing is required, fine. But if laser is required, then we'll have to give laser. And if you don't come, then probably this baby can go blind. So this is a that communication skill and
Absolutely.
counseling is part of the treatment. Third is that while dilating the pupil, we should dilate 50% of phenylephrine and tropicamide. That 1:1 that people usually forget. and
Nowadays,
only one
actually,
drop
there
is
are
enough.
ready drops available, T plus semi or something which we are getting here. So that
Yeah.
drop is specifically prepared for the ROP screening.
Yeah, and another is that these days there are special bed, warmer bed, so they keep the temperature of baby stable. Otherwise, the baby, these are very thermosensitive babies, so they are very small baby, and they are not wearing good, I mean, good clothing. Then, so it is very important if they are coming to the ophthalmic OPD. So I think these are certain points which should be taken care of, and we should have proper diagram and proper that recording means we should have documentation,
Documentation.
proper documentation.
Absolutely.
Also, one more point I would want Dr. Pratik to opine upon is when we do scleral indentation, like depression, to kind of examine the periphery in indirect ophthalmoscopy, both at the beginner level, also when you kind of get more comfortable with the instrumentation, at times the patients can be really sensitive to our touch. Also, when we are using either a Q-tip or a thimble to depress to examine the periphery. Could you opine as to how things can be made easier for the patient and such that the experience towards the patient is not unpleasant?
Absolutely. So one very simple clue is that, for example, I'm going to examine the superior periphery, right? And for that examination, I want to indent the superior periphery. So first, ask the patient to look down. You will get a good exposure of the superior area. Now, put your indenter and just ask patient to move. More importantly, here one key important point is that our whole aim is just to uh, elevate that area of the retina apart from the rest of the globe, not to touch, not to depress, or not to do it like what I can say, the George, it should not be, it should be very gentle, just mild elevation of the retina. You will be able to perceive. With no like with very much pressure or something like that. Do it very gently. Initially, even sometimes, many times what happens that even patients sometimes feel that scary because of that steel instrument which we are going to use it. So what I even sometimes for those kind of the patient, like for example, our LASIK patient, each and every LASIK we are going to screen, and that young girl is like, "What is sir, ye kya dal?" Then we use that kuchi, that soft tip. Even we can use that soft tip. So it is not something very mandatory. You just show them, okay, this is a cotton bud, and we are just going to use this. So those are the little tips and tricks with which we can make it little easy.
And so, if you could also possibly opine on the protocol you use while performing your vitreoretinal surgery at times that you want to visualize using an indirect ophthalmoscope in the theater. So, what should a surgeon know? What should your assistant know? And what should the onlooker or the observer know about how you handle your indirect ophthalmoscopy, what sterilization to follow, and basically the mechanics that go about the patient under local or general anesthesia when you want to see something using indirect ophthalmoscopy during surgery?
So basically here there are two important things. One is एक तो lens आपका we are keeping a separate lens. We are having that luxury of having a separate lens for the OT. So that lens is remained ETO वाला, वो पूरा sterile रहता है. More importantly is handling that indirect, especially you are scrubbed. Now in the middle of the surgery, you want to take that band. So we take two things. One is like whenever we wear the indirect ophthalmoscope, we do it. You consider that your hand had touched somewhere, you change the gloves. That is one very simple thing. There are other way that there is a bag which we keep it, and with that bag we try to hold it and do the proper adjustment. That bag is generally sterile. That bag we keep it from the shoulder to down, and that is again one of the way with which we can do. Now, but another part which is important is when we are doing the indirect ophthalmoscope in the theater versus when we do the indirect ophthalmoscope in the OPD, the difference is the anesthesia. When we are doing it in the OPD, patient is completely able to follow your commands. You are able to indent, you are able to ask the patient to move your eye in the direction. But when we are doing it in the theater, that advantage is not there. So you have to understand that part. That's why I said that indirect ophthalmoscope again, your dorsal flexibility is again one of the very important thing. Otherwise, you will get the backache and all those things very easily. So that is where. So in the theater, you can use that kuchi and all to rotate little the globe. Initially, you try to move yourself even little more, and in that way we can make the little more adjustment. Yes, that is one of the very simple. If you have already threaded the recti, आपने bridle कर लिया है, that will again little help you. These are the little tips and tricks that this is the major difference in OPD indirect and the OT indirect.
All right. So, any experience with the use of multimodal imaging in your practice? Like if you combine FFA, ICG,
With
FA,
ICG, yes.
plus apart from your clinical exam, apart from using OCT and OCTA for a particular pathology, how do you put across the investigations to the patient and also to the center? At times, people might have the luxury of having all the instrumentations at one place versus some hospitals which tie up with the other diagnostic centers where you have to refer a patient and also keep the either the person who's in charge of the diagnostics or the doctor present there or the optometrist in loop. So how do you navigate around explaining to the patient and also to the diagnostic center about the importance of having these investigations in the pathology you're dealing with?
Adaptive, what we were, so multimodal imaging is one of the very, very important thing and boon in a current era. If we use the FF and ICG combined, then I will say that it is little limited because honestly speaking, ICG's role is again day by day declining significantly because now we are able to imagine the retina with this sub source and the more depth imaging. The PCV and all diagnoses are very easily made with the OCT itself only. So day by day, the ICG's role is definitely declining. But in case whenever there is some challenge or you are feeling some unusual telangiectatic vessels which you are not able to diagnose what exactly you are feeling, why it is there, and in those kind of the certain challenging cases, this multimodal imaging will be a definitely boon because you are able to see the choroid, you are able to see the retina, and in case you require some specific area to be scanned with the help of the OCT, that is also possible. Yeah, OCT and the FFA combined is utilized so frequently. In diabetic cases, then you are seeing angiographic lesion as well as the edema, everything in a single is, it's definitely a costly unit. I had a privilege to use it only till I was a part of the institutional practice, till Arvind and all. After once we are in a more into this side of the private or corporate practice, multimodal imaging is not something which is as of now accessible to me. Um, but yes, if it is available, it's a boon. But it's again, whenever you want to invest, it is always a investment cost versus return ratio, and that is because of the lesser popularity of the ICG, lesser popularity of these certain modality. Many times, it's not like a very rational thing to invest in an individual's practice. That's what I felt because none of these instruments are less than a crore rupee. So yeah, if you have a very good practice, then definitely one thing you can go for. Now, if you have a referral center of diagnostic where these things are available, then definitely it's one of the very good thing. कि हाँ आप जाके वहां पे करवा लो. Most of the time in Surat we have certain, they always keep it as a neutral center, and generally it's sometimes very easy. Okay, we want to do this investigation, this will be done there. A patient can come back with that investigation with a CD if possible. That is one of the very good thing because most of time these are the dynamic phenomena, and if CD is not then I generally ask for the OCT. Like OCT as of now, we are having it. Like in case, for example, some there is some breakdown, and if we want, then we want them specifically. We instruct that person, you make a print through the area, exhume pathology scene, and give me 3 or 4 print. Like in the area of the surrounding as well. Like for example, CNVM is there, and if in certain scans that is appropriately not seen in certain area, you can see. So those are the, like if we are getting at least 3 to 4 scan in from a referral center, if it is only a print, that will be one of the very important things. So when we are sending it to the neutral center, your communication with the angiographer or your communication with the optometrist who is going to perform the OCT is very, very important. Especially when sometimes we do the OCT for just to avoid the, like I'm in a multi-specialty. We are having even a nephrology unit where dialysis patients are there. So we can't do many times on a certain patient the angiography, FFA, we can't do. So in case if I have some dilemma that there is a IRMA or there is a properly fluoride NVE, and I'm having a little doubt, okay यार ये क्या है? And we ask our optometrist specifically, मैं पेपर पेन से डायग्राम ड्रॉ कर देता हूँ, हाँ यहाँ पे ये एरिया है, यहाँ पे मुझे डाउट है कि ये इरमा है कि एनवीई है. You do the scan, we do the raster scan, which have a very high clarity for that specific area, and we will get all those details quite more easily.
And
If time permit, can I
yes,
ask a quick question just to
yes, ma'am.
explain, Pratik? Pratik, it's just a basic for the PG because this forum is this
I
today's
understand,
topic
ma'am,
is
but
for the
question is there, so I have to
PGs. So I'm just asking you to explain the PGs how to draw a fundus diagram when you are seeing the indirect ophthalmoscopy, because many times they are seeing something at the superior temporal area and they draw somewhere else. So just few tips for the PGs to how to draw a fundus diagram.
That's very important. So, when you are drawing the fundus diagram, first to understand that image here in indirect is inverted, upside down, as well as right to left. But this is very tricky statement. Listen me, this is very tricky statement. This will be, this inversion is only limited to the area which is enlightened or area which is illuminated, not for the entire eye. So, for example, if I'm asking my patient to look up, and I'm trying to examine the retina superiorly, then believe me, this area is superior in your fundus diagram only, but area, the image of the superior retina is reflected. So, for example, if I'm asking the patient superiorly to look up, then I'm seeing this retina. Now I'm able to see that 12 o'clock to 1 o'clock lattice. So I'm supposed to invert this lattice in a superior area only, not it should be in the inferior area. Because we are seeing the retina not entire at a one, we are seeing the retina in almost 9 different quadrants. We see the retina in a superior, superinasal, nasal, inferior, then 8 meridians, and then the posterior pole, and then the equator or in between area. So try to understand the image of whichever area that is illuminated, that particular area is only reflected. Yeah. One more simple tip, if you have posterior pole pathology you are looking at and some confusion, then patient is like a supine position. Now you are standing towards the head, you just rotate your chart, or you keep your chart correctly because patient is now inverted for you. And just whatever the posterior pole detail you are seeing, just put the posterior pole. Again, this is only for the posterior pole. If you are seeing the caliper is superior, is the superior right? Okay. Anything else if I can add?
No, that is fine. Good.
Thank you.
Yeah. Any other questions for any of the two speakers from all the panelists or any expert comments on the session this evening before we call it?
If somebody can highlight on the color coding for diagrams for postgraduate students, because it might differ from center to center. Is there something that all the postgraduate students can refer to one?
Madam, if may I add, sorry, sir. We have done a 1.5 hour program on various color codings in ophthalmology. Retina is huge. It will go for a long time. Cornea, even anterior segment, retina, cornea. We called it color coding and diagrams. You know, one of my PGs she was failed because she didn't draw a iris vessel with the color coding, new vessel. So actually, we can request AOS to do one exclusive program on diagrams and color coding for postgraduates, madam.
Yes, that's very rightly said, sir.
Any further questions by any of the panelists or comments for the session?
I think it was wonderful topics and wonderful discussion and a lot of enthusiasm amongst the panelists and the speakers. And we do not know the responses of the residents or the observer or the listeners. So is there any question from their side also?
I had a few questions which I've put across to Dr. Pratik.
Okay.
Yes. We, in the continuum of the same as GuruSangam, the 2025 edition, the session 2 is tomorrow, and it is from 10 a.m. to 1 p.m. and the topic being clinical evaluation with a lot of interesting talks and different speakers. So I request everybody watching this live to join in tomorrow as well for a wonderful session. I'm looking forward to that as well. Thank you so much from the bottom of
Thank
the
you.
to all the expert
So
panel.
Subhav, what is the platform like? This is AIS 1.
This is AIS GuruSangam session 1. The session 2 is tomorrow, sir.
No, and people can watch this on AIS.
Live. Yes, sir. On AIS Live. On YouTube.
Even it
Yes,
is
right.
on YouTube also, I think.
YouTube. The link was given, sir. Link has come. So
Yes.
thank you very much, Dr. Subhav, and all the learned experts and my co-speaker. It was wonderful learning experience. We'll catch
Thank
up in
you.
some other
Absolutely, sir.
program. Thank you so much, sir.
Thank you so
Thank
much.
Okay,
you.
thank
Thank
you
you, sir.
everyone. So nice meeting everybody.
Likewise.
Sure. Same here, sir.